All right, thank you so much for the opportunity to present our work today. So as we all know, hundreds of thousands of patients in the US are diagnosed with a groin hernia every year. And obviously the first important decision to make is whether or not to undergo surgery at all. But for patients and surgeons who have decided that surgery is perhaps the right thing, the really most critical decision is which type of operation to have. And we've seen a ton of presentations and debates this week about, is it robotic, is it a tissue-based repair? But at the end of the day, I think the thing that we're often deciding about for the typical patient is MIS versus open. When you look at the guidelines, there's really only a few cases where one approach is definitely recommended over the other. I know we all kind of have our opinions. But for MIS, it's usually bilateral hernias, since you can repair them at the same time, and some recurrences after open repair, maybe some subgroups like females who recommend using MIS. And similarly for open, there's definitely a few times that perhaps when a patient can't tolerate general anesthesia, or again, if they've had a recurrence after a minimally invasive repair. And I think, the reason that there's kind of this equipoise between the approach is because when you look at the totality of all the studies that have been done, we don't really see a clear winner. And I think although we all think we know which one is better, for example, this study was published just last year. They looked at 35 different randomized control studies looking at approach and basically found that recurrence is super, super low, around 2%. And it didn't really matter if you had an open repair, a TAP repair, a TEP repair. So then it really begs the question, why even reinvent the wheel? Why study this? I think for me and our group is that while there have been a lot of randomized control studies to ask this question, there's still some big holes or kind of questions regarding the data. And I think the biggest one is, randomized control trials are obviously optimized to answer a really specific question. And so as a result, they often include kind of homogeneous or very similar types of patients, so younger patients, healthier patients. In the case of groin hernia repair, it's often all males. Many studies completely exclude females, but we know in our populations that a lot of the patients we see are not young, healthy males. They're older males, they're sick, they're women. And then perhaps maybe less important, but still a concern, is that a lot of the studies we have just have a lack of limited follow-up. So with that in mind, our goal was to really determine the risk of operative recurrence up to 5 years among a truly pretty representative sample of patients in the US. To do this, we used a 20% Medicare sample, so contained claims from both inpatient and outpatient. It was, again, kind of a representative sample of about 20% of patients. And while you could say maybe Medicare is not the most representative sample because it is mostly older adults, it does have, a good distribution of female patients, patients with disabilities, patients with a lot of different comorbidities. And the best part of it is it has very robust long-term follow-up, which is an advantage over some different claims registries and databases. We looked at patients undergoing elective groin hernia repair from 2010 to 2017. To first estimate kind of what's the overall risk of recurrence, we used a Kaplan-Meier analysis, and then understanding that there would probably be differences between who got open, who got MIS, we used a multivariable Cox proportional hazards model. So just looking at the trends, obviously this data is still a little bit, 2017, we're in 2022 now, but we can see that obviously over time MIS has increased. So at the beginning of the study period, only about 15% of patients were getting this approach. And by the end of the study period, that had more than doubled, so that about a third of patients were getting it. In our study, and again, this was a 20% sample, we found 120,000 patients, and the vast majority, 76%, underwent an open procedure. The patients in the open cohort, not surprisingly, were slightly older. Surprisingly, though, there was more females in that group, which is counter to what you would think based on the guidelines. But overall, they had a higher prevalence of pretty much every comorbid condition that we looked at, so hypertension, diabetes, et cetera. MIS, the main difference that we found there was, not surprisingly again, more bilateral hernias. And then looking at the results, just in the unadjusted analysis, we found that patients undergoing open surgery had a slightly lower risk of experiencing operative recurrence. And again, these numbers are low, but I think there's a couple important things to notice. If you'll remember the meta-analysis that I referred to earlier, they found about a 2% recurrence rate. And so this is like 2.5% higher than what we would anticipate based on the randomized data that we have. And the other thing that I found interesting was that a 1% absolute difference doesn't seem like a lot, but when you think about the number of patients that get this procedure, it's really a 20% or about like a 20 or 25% difference in rates of recurrence, which is pretty substantial. And again, when we did our adjusted analysis, accounting for patient characteristics, patients who are lost to follow-up, we found that patients in the open cohort had a significantly lower risk of experiencing operative recurrence. So there's definitely some limitations to this study that I'll discuss. The first is that we really only captured operative recurrence. And so claims data is notorious for not being able to capture patients who have a recurrence that perhaps don't get operated on. Some of the literature suggests that this underestimation could be up to 40%. And that may be important when we think about the open patients that were a little bit sicker, a little bit older. Maybe they were having more recurrences, but we just didn't find them because by the time it happened, they were too frail to undergo reoperation. The second is hernia laterality, which is one I struggle with a lot. You obviously can't tell if they had a right-sided hernia repair, left-sided hernia repair, so we may be misclassifying some patients as having had a recurrence when they were really just either having a staged or a later repair of a contralateral hernia, but we don't really anticipate that that would be remarkably different between the two cohorts. And then finally, while we did not in this study account for surgeon expertise, we know that that's a huge component of this, and so we're actively looking into that in our next steps. So thinking in the future, I think the things that I'm interested are, we see this kind of small absolute difference, but are there certain populations that might benefit even more from one approach or the other, particularly patients, female patients or octogenarians? Thinking about surgeon volume, especially in our current era, where this is more common, trainees are getting exposed to it more often, and we have some different techniques to help us improve our outcomes. And also, what is the effect of some of the other things that have been happening around this time? Obviously at the beginning of the study period, ideas like the critical view of the myopectineal orifice had not even been published yet. And so understanding the impact of some of these other interventions on outcomes over time is of interest. So with that, I'll stop and say thank you very much and happy to take any questions.